Alexandra, is that you?
Yeah, I started the recording.
Okay, good. Okay, well then I think we should kick off. Yeah, I posted my welcome also in the chat, but welcome. My name is Erwin Spekle. I'm the co-chair of this technical committee. On behalf of Steve Fisher, chair of the technical committee on musculoskeletal disorders, I welcome you to this IEA Journal Club webinar on MSDs. It is indeed a truly international event, and we are very happy to welcome approximately 100 participants from all over the world. I'm reaching out to you from the Netherlands, from Haarlem. It's a very clear evening over here. And the webinar will be hosted by Dr. David Rampel from the University of California, Berkeley, but he needs no further introduction, I think. The webinar is styled as a journal club where attendees can discuss two recent MSD prevention-related papers, along with the authors who will provide context and background. Steve have asked me also to encourage you to visit our website, where you can read our new vision to 2023 and beyond. And the goals of this technical committee are to continue to grow and connect our MSD prevention community around the globe, host more routinely organized webinars, and support other activities that continue to engage and keep our MSD community well informed, and last but not least, continue to expand the impact of MSD prevention research and practice. Well, without further ado, I would like to hand over the word to David Rampel. Please, David.
Great. Thank you, Erwin, and thank you all for attending this first Journal Club of the MSD Technical Committee. We plan to do more, and we invite those of you who would like to organize a webinar on this topic to please let Erwin know, and we can schedule something like that in the future. And also, if you want to participate in the technical committee, there's other activities besides webinars that we're working on. And as he mentioned, please visit the IEA website and look at our webpage. I want to make a few quick announcements. One is that the IEA and the ILO recently published a new book called Principles and Guidelines for Human Factors Engineering, Ergonomics Design, and Management of Work Systems. It's on the IEA website, and I think it's worthwhile checking out. It's, again, an international group of authors that contributed to that. So the format for the meeting today is that we'll have two papers presented briefly with PowerPoint slides, no more than about 10 minutes or less. And then we'll switch to a Q&A process. I have questions for them about their papers, but you might also. And if you do, please throw your questions up in the chat box, not the Q&A box. And I'll try to manage those and get them to the speakers. We want this to be informal. Have your coffee or tea ready or whatever helps you get through journal clubs. Thank you. And we'll kick it right off. So, but first I'd like each of the panelists to introduce themselves. Suyoung, why don't you start? Give us a little bit of background and where you are now.
Yeah, so hello everyone. My name is Suyoung Kwon, and as a background, I was working as an occupational health nurse for manufacturing companies, and then completed a PhD program at University of Washington, and then now I'm working at a postdoctoral scholar at the University of Washington. Yeah, thank you.
Thanks. And you're now in which city?
Now I'm in Seoul in Korea to meet my parents, so it's kind of very early morning.
Good, great. Well, thanks for joining us. Stephen, do you want to introduce yourself?
Yeah, my name is Stephen Bao. I'm an ergonomist with Washington State Department of Labor Industries. I've been here for almost 25 years, and basically doing the same thing over and over again, research. So I'm more in terms of specialty. I'm doing and exposure assessment methodologies.
Great. Thanks for participating, Stephen. Stephen was involved in the same paper with Suyoung. And then Judith, why don't you introduce yourself anywhere you are?
Thank you, David. My name is Judith McKenzie. I am an occupational and environmental medicine physician. I am also trained in internal medicine. After practicing internal medicine for a few years, I found this wonderful field. And I was at the University of Pennsylvania for many years. I am now at Johns Hopkins, and I take care of workplace injuries and exposures.
Great, thanks, Judith. So I think all of you know that the purpose of a journal club really is to bring us up to date on new publications and research, but also to get some insights into research methodologies that will help improve the research that we do. So to kick it off, Suyoung, why don't you take over and share the screen if you want, or make your first presentation.
Okay. Yeah, I'm pleased to present a paper called Identifying Optimal Cutoff Point Musculoskeletal Pain in Upper Extremities to Prevent Lowered Work Performance. This study is funded by Hester McLaughlin Scholarship and US NIOSH and the Washington State Department of Illinois. So we know that early intervention of musculoskeletal pain is important. This is study, but focus on more secondary prevention, because we know that musculoskeletal pain in upper extremity is very prevalent and recurrent among the general population. And even though they have a musculoskeletal pain, they going to work. And also I want to focus on the loss of work performance. A theory conservation research by Hoffel talks about the initial resources loss calls for the further loss. So it's more important preventing loss of resources rather than gaining resources. And we know that chronic state of musculoskeletal pain have lots of problems. So one of the problem is they have maladaptive stress response we call the suffering. So because they have fear and depression, so even though the musculoskeletal pain is pretty low, they're more likely have work disability. So based on these things, I thought that maybe initial loss of resources could be the slight loss of work performance. And thirdly, I focused on looking at the overall musculoskeletal pain in the upper extremity rather than only one body part. The previous research talks about that people who have a right wrist pain more likely developed right elbow pain or left wrist pain. So in this study looking at the overall pain status in the upper extremity. So the purpose of the study is to drive a composite MSP index for the upper extremities. And secondly, to identify the point when most workers start experience a decrease in work performance. This study is a secondary analysis using the data by Sharp in the Washington State Department of Labor and Industries. Sharp team conducted a prospective cohort study for full-time workers in 12 different manufacturing and healthcare facilities in Washington State from 2001 and 2004. They collected three different types of data. First one is they collect individual biomechanical factor assessment by ergonomists. And second, they conducted health interview by trained interviewers to collect health history, job history, and musculoskeletal pain status. And third, they applied the self-administered psychosocial questionnaire. For this study, we used only baseline data. And after a subject who had a sudden injury in upper extremities within a year, the total number of samples was 704. So for musculoskeletal pain index, we summed all the intensity for 6 body parts. they asked the rate pain intensity during the past 7 days, and it is recorded non-mild, moderate, severe, and very severe. So unweighted MSP index is ranges 0 to 24. Also, we tested whether impact of each body part on the work performance are the same or not. And by the test, we found that impact of hand and wrist is more than other body part, about 1.8 times more. So we decided to give more weight for weighted MSP index. So as a result, it ranges 0 to 30.4. For work performance, participants fill out the 4 question that the tool is Dash Work Module. They ask 4 different kind of question. Ask about the difficulty maintaining the speed of work and the quality of work, and difficulty, some work interference because of their musculoskeletal pain in the upper extremities, and then any difficulties using a user techniques. So higher score indicated high work disability. So, but also there is some reference range using a healthy US working population based on gender and the age group. So individual score was compared to the reference group and then grouped into their low or high work performance compared to their reference group. For statistical tests, we use receiver operating characteristic curve analysis. This is the test to calculate the sensitivity and specificity based on each MSP index. And for this study, we try to determine optimal cutoff is the point where maximize some of the sensitivity and specificity. So these 2 graphs and shows the result of this study. So on the left side, we can see our C curve. So a solid line indicate unweighted MSP index, and then dashed line indicate weighted MSP index. As you see, at first, maybe weighted MSP index is a little higher AUC, but later they are almost the same. So an area under the curve for 2 MSP indexes shows that 0.81, which means it's they discriminate pretty excellently between low and high work performance. So we try to find the part where the maximized sensitivity and specificity, and that is a cut point of 2 for both MSP indexes with 0.79 sensitivities and the 0.69 specificity. And the graph on the right side shows the distribution of the participant based on high and low work performance. So the vertical line indicating cutoff 2. So as you see, people with the high work performance, they are more on having a lower than 2. But in the low, people with the low work performance shows that they have more having a cut point of 2. So based on just the distribution, we can see that maybe cut point 2 is pretty discriminated who has high or low work performance. However, this study has some limitations. First thing is related to generalizability. So the original study using some criteria. So as I mentioned, they collect the data, they collect musculoskeletal pain status by interview. They are kind of structured interview using body map, ask about wrist, and ask, have you had musculoskeletal pain at least 3 times or less than for at least a week in the past 12 months? If the participants say yes, then they ask about pain intensities, they ask about work performance. However, if they say no, then they move to another, body part, elbow. And then if they say no, then they move to shoulder body part. So those who said no, all body part, they didn't ask about pain intensity or work performance. So for this study, we assume that those people are no musculoskeletal pain and no work disability, so no loss of work performance. So that's why, because of that, this study maybe only apply who meet this MSP criteria. And secondly, when they collect musculoskeletal pain, they use a verbal rating scale. This is not equivalent to other type of scale, numerical rating scales or visual analog scale. And the other limitation is related to validity. So gold for RC curve analysis, they have to use gold standard for the outcome. For this study, is work performance. But there is no, to my knowledge, there is no gold standard to measure work performance. So if dash work module is not a great tool, then maybe this result is not valid. And this cutoff 2 does not consider prevalence of the cost ratio of a false positive and false negative result. So if we have this information, then cutoff 2 can be changed. So cutoff 2 can be achieved moderate rate of pain in the upper body or multi-site of more than 2 body parts, even though they have a mild pain. So as a conclusion, when workers experience moderate or multi-site musculoskeletal pain, they are encouraged to seek help. So this is more like provide information for workers and employers to let them know when they have to contact the professionals. So lastly, I thank for the SHARP team for me to enabling analysis this data set. And thank you. And then I'm happy to get any question and feedback and comments.
Great, thank you, Suyoung. And I have, again, if those who are attending want to put the questions in the chat box, they're welcome to do that. And if you'd close your screen, I don't know. Mm-hmm. There we go, good. Thank you. So I have actually a lot of questions to talk about. There's a lot to talk about here. It's a dense paper, complicated. Some of the issues are complicated. And I want to start off maybe with the conclusion, a quick one. This threshold of 2, based on your MSP score of 0 to 24, I'm trying to translate that into a clinical setting. Whereas clinicians, when we see patients, they fill out, a pain score of 0 to 10 in specific body regions. Mm-hmm. And if we see them and they have a pain score of 0 to 10, like 4 in their hand or wrist or elbow, how do we translate that into, how do we translate your information into our recommendations in the clinic setting for whether people should get help or not? Because 2 is a pretty low level on the scale of 0 to 24. So what are your recommendations?
So my recommendation is it's not equivalent. So we know that mild and moderate interval is not the same as severe and very severe interval. So this we call the verbal rating scale. This type of non-mild severe. They kind of have a lack of racial property. but it's good for just the typical people, general population, rather than health professional. So this is not equivalent to 0 to 10 scale. So that is a kind of limitation of this study. So have to have a verbal rating scale.
Good. Yeah, I'm trying to translate it because in the clinic setting, when we ask patients these questions now, it's always a 0 to 10 scale. It's standard.
Yeah,
Mhm.
I think that's a good point. So for practitioners, they might be able to use the finding. So since to understand the overall score, we use the 5-point scale from 0 none to 4 severe, and then it covers 6 different body parts. So probably what you can do is you ask the patient about different body parts and then scale it back from 10 point to 5 point. And then you need to do some calculation yourself rather than just use one single body part of the 10. Yeah, I think it should be possible. Yeah.
Okay, well, it'd be nice to have that translation because it's useful in the clinic setting to understand, when someone comes in and reports pain, it's complicated because there's cultural differences in pain reporting that we all know about, and people have different levels of pain that they report. So it's always an issue of when it might affect their productivity in work and when should we intervene at work. I have a methodology question for you on the 209. There were 209 people in your study out of the 703 who filled out the DASH questionnaire. And as far as I can tell, those 209 were the only people out of the 704 who reported pain in the last 12 months. So the other 494 people did not report pain in the last 12 months.
Mhm.
So basically, those 494 people who did not report pain, they all got a DASH score of 0.
Yep.
You assign them a DASH score of 0.
Mhm.
And so when I'm looking at the low work performance group, 209, and the high work performance group, 495 or 494, the low performance group were the ones who had pain. The high performance group didn't have any pain. And so when you're looking at those kind of differences, clearly you're looking at 0. Everyone in the 0 DASH group has 0 pain. So isn't it really easy to distinguish in your analysis between those who are low performance and high performance? I mean, all you need is a little bit of pain and you're pop up into the low performance group based on your analysis. Is my interpretation right?
Yeah, right. But I kind of missed the last part. Could you repeat?
Well, I'm thinking that you basically have an inverse ceiling effect. You have 494 people who have 0 pain and their DASH score is 0. That's kind of your comparison group, and it's really easy to distinguish them from those who had a DASH score of 1 and above. Like a pain score of 1 would distinguish the two groups.
Yeah.
So to me,
yeah, go ahead.
to me, it would have been more interesting to do your analysis of only the 209 people who reported pain and split them into 2 groups, a low work performance group and a high work performance group. And then in that group of 209, try to identify the threshold of pain that distinguishes the high from low group. And I'm wondering if you did that at all.
I think that at first I did that direction first, but as you know, that 209 is pretty small, and then the result is kind of a little weird to me. And then at the time, I talked to some other people and decided, why don't you just including healthy population who doesn't have a pain, because we just looking at the work performance because of the pain. So that is why I did. But as you mentioned, that is also a good idea if we have enough sample who had a pain, and then they rate all the work performance.
There was another question here from Matthew. To what extent are comorbidities like obesity and previous injury considered in your analysis?
I think that I didn't account for obesity, but for they have I exclude the people who had a certain injury in the upper extremities. So because this is more non-traumatic musculoskeletal symptoms rather than traumatics. So for this study, I exclude who had a certain injury in the upper extremities.
And I noticed that there were differences in male and female in your study sample who filled in the dash. There were more women who filled in the dash report than men. And I don't know whether you did an analysis, were you able to break out that group in male versus female, if you recall?
Okay, yeah. So for DAS score, I compared the reference group. So there is some reference mean based on age group and then gender group. So each individual is just compared to their reference group. So yeah, and older people and the female gender more likely have a loss of work performance, but they are compared to the same reference group. So.
Got it. Thanks. There's some notes here about background noise. Is there still background noise? I don't hear any background noise.
Yeah, I heard that, but now it's muted. Yeah.
That's quiet. Okay, cool. Other questions here from Paul. If you would have got the data about the self-reported work-relatedness of pain, would that change your conclusion? That is, if the pain was reported as work-related or not.
So this study does not include only work-related, the pain. It's whether the pain is work-related or not work-related is more complex. This is more like, even though their pain is not work-related, but if they have lots of, interference with work, then maybe it has more some aggravated their symptom. So this study is just looking at general musculoskeletal status and then how impact on their work. Yeah.
Okay, good. And then I think it's Jack. It's a question. What other research can you refer to confirm your findings, or that you can compare your findings to? And do you think that the findings are ready for prime time? Are they ready to be applied in a clinic setting, or do they need to be confirmed with other research?
Yeah, so when we started this musculoskeletal study, the first time they used some criteria, kind of meaningful pain status as like a moderate pain and 1 week duration and 1 month frequency. But they just made that kind of criteria with the expertise, but they don't have any data to support that. And the other United Kingdom guideline of musculoskeletal pain management, they use some moderate pain and then some duration. So in case of the pain intensity, moderate pain is kind of concurrent with the previous guideline. And then also we have lots of study talks about the multi-site pain. So this study also kind of add up to the multi-site pain is also related to work performance. So this result is not kind of new, and then it's very concurrent with the previous studies.
Thanks. I'm going to actually draw in Judith here. You know, as a clinician and seeing lots of patients in your clinics with musculoskeletal pain in the hospital setting, how do you think the study like this might be useful in your setting?
I think it's always helpful for the clinician to have data when they're evaluating patients, and especially consistent data across different patients, because then they can use that to sort of temper what they're hearing when the patient gives this subjective description of what's going on. So I think it could be useful if it's used often enough, so it's comparative.
And what about this idea? I'll cross it over with Anna Christina Arnold's question. You know, people that we see in the clinic with musculoskeletal pain, some of them come in with, it's only in my wrist, it's only in my elbow, it's only in my shoulder, and some of them come in with pain all over, you know, pain in both extremities and wrists. And would an analysis like this help improve your perspectives on managing them with multi-site pain rather than single-site pain?
That's kind of a tough one. I mean, it could. It definitely could, depending on, you know, I think sometimes the clinicians are so busy that unless they're used to a tool, it might be difficult to incorporate it into practice. And so, I mean, that might be a good pilot study, actually, to, you know, see if clinicians will be interested and patients will be interested, and sort of have this as a part of their routine evaluation before they show up, and test it that way, I think.
Yeah. I'll take one more question from Anna Christina, and that is, what do you think about extending the model, and maybe you've already done it, extending your analysis to back pain? I know that you guys are studying back pain and shoulder also pain, but have you tried doing the same kind of thing with back pain, or are you planning to?
I would like to do the back pain, but I didn't start it yet. But I think that back is actually one of the common pain, and then very related work disability. So probably it's very informative information, and then also maybe it's better to just combine all body part. Is also kind of informative. Mm-hmm.
Yeah, because I guess with the back pain, you'd think about various body parts, low back, hip, you know, lower extremity. So you could think about it as a multi-site pain also. Good.
Mm-hmm.
So I think we'll transition there, except Stephen's been awfully quiet.
Well,
And I'm wondering if, Stephen, if you have any final comments before we shift it over to Judith.
Yeah, I think, as I mentioned to your question, I think it's possible to apply this to clinical setting, and we just probably need more data. And as you know, all data is kind of limited, and we collect dash on some workers, but not on others. So I'm just wondering whether, and I saw Krista is here, whether the consortium and the whole big consortium has more data, and then probably can get to see whether we have similar findings, especially with the Italian data. In terms of the back, I don't know, I saw Jack and Louis here. So whether a NIOSH back study has some similar data like this, and then so you may take it over to do your postdoc study project. So I think this is interesting. And especially for the study analysis, because I'm not really that familiar with some of the statistical method. And they were able to, she was able to put 1.8 times weight there for the hand wrist. I thought it's very interesting. It makes sense too, because hand wrists are more involved in performing jobs. So I think those kind of weighting methodology is very interesting, I think. And it can be applied to other things like exposure part. For example, if you have higher exposure on the back and the hand and arm, it probably relate to different job performance as well. So the methodology part is very interesting, I think. Yeah.
Well, thank you. Thank you both for the presentation. And by the way, Jack Liu stole my name. So in the chat section, if you see David Rempel there, it's really Jack. Anyway, so Judith, let's pivot to you now and have you talk about your study of hospital work and the people were using it transporting workers on motorized stretchers.
Okay, thank you. I'll share my screen. Okay, I think I'm good. So I'm going to talk to you today about a study we did on the effect of introducing motorized stretchers on injury occurrence and workers' compensation costs in transporters. It was a resident project, so I worked with Dr. Blythe Mansfield, who was our resident, and our statistician, Francis Schofer. It was partially supported by training grants from NIOSH and HRSA. Okay. So the objectives of this study were basically to look at the impact of introducing these stretchers on injuries and workers' compensation costs, which I mentioned. And the conclusions were that they were associated with reduction in number of injuries and lost work days. Why this study? As an occupational medicine physician, seeing patients at work, I would see people who came in with injuries manipulating manual stretchers. And I just thought that it was really quite preventable. Transporters have a very demanding job physically with pushing, pulling, lifting, awkward positions, and they're injured anyway just from moving patients. But I thought the stretcher should not hurt them. So they would say things like, I was pushing up an incline and I twisted my ankle because it was so heavy. I felt my knee pop. I lost control and it hit the wall. I had to hold the stretcher plus the IV pole, and I was manipulating both, and it was difficult to turn the corner, things like that. So what I did was I sort of looked into the issue, and I saw that the prior year before the study, when we looked at injuries from transporters, a third of the injuries were due to stretchers. And they were the more expensive ones because they ended up for 60% of the cost of taking care of the worker, giving lost wages when they were out of work. And so the question was, would the use of motorized stretchers be cost effective? Can we sell this to management so that they would buy more of those, or at least buy them, period? And then we also think about the intangible human costs, the pain of injury and psychological anguish of not being able to work. We did a retrospective study of the medical record from January 2013 to December 2016, and looked at all transporters who presented to the clinic with a musculoskeletal injury. It had to have to do with transporting, lifting, maneuvering patients, the work of transporting, not some other work, even though there were transporters. And we looked at sex, birth, job category, body part injured, how were they injured, and the type of injury. We also looked at workers' comp data. We looked at the claims and looked at medical costs, which would be like doctors' payments, therapists, medications, indemnity costs, which is like lost wages, paying people while they're out of work because they're on disability from work. And also expenses such as legal costs, surveillance. And we also looked at lost work days and modified duty days from these claims data. We also discussed with purchasing how many motorized stretchers were purchased. After they saw the initial data, they agreed to purchase some stretchers and the purchase date. So that would tell us what time period we would look at before, after the introduction. For statistical analysis, we use summary statistics, frequencies, percentages, means, standard deviations. Median and range were used for restricted lost days and cost. Number of stretcher injuries was per 100, calculated based on the total number of transport workers in that year, which ranged from 69 to 76, depending on the year. We use a non-parametric test to look at costs and lost work days and used assess. So the results from this table, there's some data there, but there were 96 injuries in transporters during this period. But 39 met the criteria, which was injuries while manipulating the stretcher. 85% reported a sprain or a strain. The age was pretty young, 30, 34, 35. Male and female, pretty much the same, a little bit more female, with the number of years worked, not that long, 7 years. And back injuries were the most common, followed by knee, and then upper extremity injuries. The results showed that the number of injuries declined from 2013 to 2016, 24 per 100 in 2013, and it dropped to 8 per 100 in 2016. With the stretchers, 6 were introduced in 2013, and then 3 more were introduced later on. Okay. We found that there was a greater number of lost work days among the 18 transporters prior to the implementation of the manual stretchers. At the top, you'll see the number of workers actually of the 39. So 18 were in 2013 and 21 after the stretchers were introduced. The motorized stretchers were introduced. The median lost work days were 24.5 versus 7 in each group. The workers' compensation claims were also higher before implementation, 1,700 approximately per person versus 1,400 per person, although that was not statistically significant. So comments, so by 2017, injuries had decreased further. This is not noted in the manuscript. Anecdotally, employees always try to access the motorized stretchers as much as possible because they were way easier to maneuver, but they were not always available. Reducing injuries and lost work days would indirectly impact medical costs in terms of workers' comp being reduced, although we found that it was not significantly lower, but lower. And but the number of restricted work days did decrease significantly, which speaks to the degree of injury for the employees being able to go back to work sooner and go back to work full duty sooner. The most prevalent injury was back injuries. Study strengths included that we were able to review over a period of years. It's an observational study, obviously. All reported injuries were captured, but if they were not reported, then we did not capture the injury. So there may have been incomplete ascertainment in terms of a limitation. The sample size were relatively small, but we basically worked with what we had at the hospital, and the entire year of 2016 was not captured. Thank you. I think I'll stop share.
Great. Thanks, Judith, for that presentation. So this was not done at Johns Hopkins. This was done at the place you came from, right?
Yeah, this was the University of Pennsylvania.
Pennsylvania, got it.
Yeah.
So again, put your questions and your comments, and I'll try to get to them. I have a few questions. What's the cost difference between a motorized stretcher and a standard stretcher? It's probably a lot, right?
Yeah, from talking to the procurement office, it's around $8,000. So a manual stretcher is $2,000, and motorized is around $10,000 to $12,000, at least the ones that they would purchase. And before we did this observational study, we actually looked at the cost that I mentioned before, where those injured with manual stretchers was higher than those injured from other reasons as transporters. And we found that the added workers' comp costs from that would have purchased 2 stretchers.
Hmm.
It was like over $20,000 more just from injury with those manual stretchers.
Well, a related question, and it crosses over with what Jack put in the comments, is really one on usability. You said that the transporters sought out the motorized ones when they could. Were there any downsides to the motorized ones? Were they too heavy to use? Were they not work in some places because they're too big? Do you recall was all the feedback positive from the transporters? Any negative feedback at all?
Yeah, they love the motorized stretchers, especially when it came to bariatric patients, because also there was an incline that they had to manipulate very often. So with a manual stretcher going down, that it wasn't even that much of an incline, but big enough where the stretcher would run away from them. Whereas a motorized stretcher, you had more control, and then pushing up that incline was also very difficult. So the motorized stretchers were sometimes managed by management for the heavier patients. And sometimes we had injured patients, employees, and we tried to say only use the motorized stretchers, but that wouldn't work because that wouldn't be fair to other transporters. So it was difficult, and then if one was broken for some reason that needs to be repaired and was out of commission, that would be an issue. I'm not sure where it is right now, but I think they've been pretty much sold on motorized stretchers, even with the increased cost.
Interesting. And does it, Colleen asked did it take very long to train people on how to use the motorized stretchers?
I'll be honest, I have not been involved in the training,
Uh-huh.
But I would suspect probably not. I didn't hear anything about difficulty training and using the motorized stretchers.
Yeah, it looks like you were restricted to, a natural experiment, an observational study. Which happens in the workplace. There are these pre-post kind of studies where you can't really get a control group. Was there a way you could have done a control group, do you think, at the hospital if you had, more money or planning, or was that, you think that would have been really difficult, especially with your small sample size?
I think, if we had buy-in from management, if we sought buy-in from management and had the funding and the resources, I think it would have been possible. But it's tough in the workplace. You're trying to create change, and the best way to do it is sort of observe what you have at the time, and it's not the perfect. You're not in the perfect position to design the perfect study. You just sort of try to do something with what you're seeing and put some numbers to it, or not. And to me, it was a significant problem that was so preventable. And the trend is that it makes a difference. Of course, there's no causality in this type of observational study, but the trend was there and continue to go down the next year.
Yeah, I think is a question that a lot of researchers struggle with, what to do with the natural experiment. Because you may be able to influence your hospital with your results with the pre-post, because they might not need more than a pre-post study with a change in price to buy into the idea of the motorized stretcher. But then if you're trying to use that study to change policy, like on a state level or a national level, you're going to be criticized because it's not a controlled study, it's not an RCT. And so this, I think it comes up a lot about how to influence policy, what to do with natural experiments like this. I think we all face that question.
Yeah, I mean, I agree. At the time we scoured the literature, there was only work on EMTs. There's nothing in there's so many things in occupational medicine that's not studied. We had another resident project that looked at ultrasonographers who have many injuries because of awkward positions. And, we did all this work and it hasn't been published. But again, it's a before after, it's observational. So it's a start. So maybe someone can get some grant funding and and do the real McCoy. But as an OC doc, whose main job is not, who does some research, but I'm not a 100% researcher, I just want to put things out there to help the workers that I see and maybe start a conversation.
Yeah, well, you obviously can influence the policies, I think, like you did at your hospital. But again, do you think you're going to be able to have an impact at Johns Hopkins? Are they going to buy a bunch of motorized stretchers now?
Maybe I'll go talk to them and maybe they will do that study with a control group, right? Or maybe they already have motorized stretchers. I haven't looked into it, but I will.
Yeah. Well, this came up, with patient lifts at the VA hospitals around the United States. Because the VA hospital spent $140 million introducing patient lifts throughout the hospitals, because there was, pre-post evidence that they're valuable in reducing injuries among nurses and other personnel. And there was the opportunity to do a control study, but none was done. And so, there was an opportunity there to influence policy nationally, and it didn't happen. So this is an issue that I think all of us struggle with. Is there a way to force a control study in a setting where there's an opportunity like that? So I really, appreciate what you did, and what we're all trying to do with these situations. Take a situation and do what we can with it. There's a lot of questions that are popping up in the chat box that are pretty specific ones. Like Matthew asked, did the workers' comp cost decrease? Was that indirect or direct cost? Do you remember which was a major contributor?
So the workers' compensation costs were reduced because the number of restricted work days were less after we introduced the motorized stretchers. So that was indemnity costs, right? That lost wages. So it was reduced lost wages. And medical was not that much of a difference. The main difference was being out of work. The ones the manual stretchers were out longer and had more restricted days, and after the motorized stretchers were introduced, there were less restricted days. And so I'm answering your question indirectly, but workers' comp costs consist of the indemnity, the medical, and so that's what we focus on.
Yeah, mostly lost time and wages cost.
Yeah.
Jean asked a question which I had also wanted to ask you. Were there any other interventions happening during that time of 2013 that might have explained the drop in injury rates?
Yeah, I thought about that. I mean, overall injury rates, to my knowledge, did not drop. There was the same patient population. There wasn't a great increase or great decrease in the number of employees. The personnel within the transporter group did not change necessarily in terms of people leaving because they were injured, or so there were no temporal trends that we could find regarding this. Yeah.
Okay. And then Ninka Howard asked a nerdy question. Did the workers' comp claims represent unique workers, or were they repeat claimants? Do you recall?
Yeah, I mean, that's an excellent question, right? Because then it could be, one worker coming 5 times, and but in general, there were unique workers.
Mm-hmm.
It was 39, and they were pretty much unique.
Got it. So I'm going to pivot now to our other panelists here, to Suyoung, Stephen, and Erwin, to see if they have any questions for you. And because we're coming close, we have a few minutes till we quit here. So maybe we'll start with Suyoung and then Stephen.
Yes, I think that maybe I was working on some under-reporting of musculoskeletal pain. So there is lots of barrier to claim work compensation. So maybe in your study, maybe it's better to just measure just the state of musculoskeletal pain before and after pain, because some workers have some minor injury but didn't notice, but maybe gradually have their aggravated pain. So I think that maybe the next time, not only looking at the injury part, maybe it's looking at the pain status, then maybe you can get some meaningful result. Yeah.
Yeah, no, I think that's an excellent idea. And, there are the PROMISE surveys out now that are really easy to use, but they're not used universally in healthcare. But it would be nice because then you could get some sort of pseudo standardization, right, to see what the pain level is. And you're right, some people may go back sooner than others, depending on pressure from work or worrying about their job. And absolutely, yeah, that would be great. Yeah.
Stephen, did you have?
Yeah. And I think this is great. You have the opportunity to do this study because you are in the hospital to do this. And I don't have any data or study to support this, but I do have some small cases similar to your scenario. Then I remember there was one time a big trucking company's safety manager asked me, hey, Stephen, can you come in to measure the shoulder loading for their drivers using manual and pallet jack, load things into the truck because they got lots of shoulder injuries.
Yeah.
So yeah, when you do the measurement, use biomechanical analysis, that's enormous loading on the shoulder for sure. And then he brought out an electric pallet jack. You just need to press one button and then things will move. That's no force at all, basically. So that's a safety manager. He initiated that I do some measurement for him, and he initiated to talk to his manager. So I wrote a report. He was able to successfully get to his manager by electric pallet jack for all his trucks, because he said, just need one case, he'll be able to buy that. It's $5,000. Yeah, so that's very easy. And I think lots safety managers, they understand that. So maybe just need to gather, instead of doing studies, pretty difficult. Maybe just get enough case studies and put them together. And I think safety managers understand that.
Yeah, I mean, that's what I did back in 2012. I looked at the cost of manual stretchers versus all the costs and found it was 60% higher, or was 60% of the cost. And so then they bought a few, stretchers. So then I followed to see if it made a difference, and then I left. So I don't know if they kept buying them, but at least when I left, they had them. But that's a great point,
Yeah. Another thing is when management do those things to their employees, it improves the morale of the employees as well. They think, okay, my employee consider my health. So lots of places, there are lots of confrontational between management and union workers. They say, oh, they don't consider our health. So that's a good investment, actually. Yeah.
Yeah, thanks for those comments, Stephen. I'm going to turn. We're at the end of our time, and I'm going to turn it over to Erwin to see if he has any last questions for Judith or comments for the group.
Yeah, one last comment to Judith. I think you certainly started a discussion in this field, and it's very important because you could have done nothing at all. And that's what we often see in a lot of organizations. And with regard to Stephen's comment on morale, I often have offered large organizations to do like a cost benefit or cost effectiveness study for nothing. And they say, no, we're not interested.
No.
The people are happy. We've done this, we're satisfied, we don't need all these economic data. So it is very strange, because you think that businesses are so profit oriented and they measure everything in euros, but these kind of things, in my experience, they just want to do the right thing, and if they have a case that sounds logical, they're more than pleased. But indeed, it's 1 minute to 10, and it's time to close this session. But first, before I do this, I I want to thank all of you, primarily David, for organizing and hosting this session. You know, very excellent and kind that you volunteered to do this. And of course, Suyoung, Stephen, and Judith for excellent presentations. And we hope to live up to this first one in the coming sessions. So from the Netherlands, wishing you a very good day, evening, afternoon, and hopefully we'll see each other soon.
Thank you.
Thank you
Thank
for the
all.
opportunity.
Thank you.
Bye.
Bye-bye.
Thank you.